and hopefully educational as well. I'd like to thank Dr. Fisher, I think he'll be here in just a minute, for going over my slides with me and kind of helping me put this together. And I'd also like to thank Miss Sharmi Schroed, who is the Vice President of Underwriting at the SMBIC here in Tennessee, who writes most of the medical malpractice insurance in this state. So the title of my presentation is It's Risky Out There, and it's going to be an overview of insurance and medical malpractice in general. So I have no disclosures. My outline is basically Insurance 101, what is it? Tort law as it relates to medical malpractice liability, tort reform here in Tennessee, tips for our graduating chiefs and those who are negotiating contracts right now, trends currently in claims, and then the cost of medicine. So going back to my initial slide, this is where insurance originated. It's Lloyd's of London. This was painted in around 1855 to an artist that is unknown, but it originated. Insurance is mainly a contract, and it's a promise to pay if something happens. And it's a little bit of an abstract product in that you're paying for a service that you might or might not get. It just depends if the contract is triggered. So you exchange a premium in return for a promise to pay. And it originated at Edward Lloyd's Coffee House in London in the 17th century. It was a place, England had become a place of maritime shipping, had a large navy as well, and ships were a very valuable asset as well as the cargoes they carried. And owners were not as apt to take risk of sailing across the ocean unless they had some type of guarantee of compensation should the ship be sunk or attacked by pirates or some unfortunate thing befall it. So this is how insurance originated. It was organized to protect ship owners and their cargoes against loss. And the most famous example of this came about in 1799 when the merchants of London sent aboard the HMS Lutine, a British frigate, a cargo of gold and silver bullion valued at around £1 million in the day, and it sunk off the Dutch coast. And Lloyd's became famous for making good on their promise to pay. They were insuring the cargo and paid the claim in full, which was an extraordinary amount in the day. It's probably around £200 million today by my calculation. And this is the bell that was salvaged off the ship. There have been many other salvage attempts to try to get the silver and gold as well. So what is underwriting? It's a term originating at Lloyd's, and these ship owners would go around the coffee house and literally get individuals of means to give them terms of a policy. Very basically, if the ship sank, we'll do X. And they would sign their name under the agreement, and that's where the term originates. Today, an underwriter evaluates a given risk presented to the company that they work for. They determine its acceptability and price it based on the company's guidelines that they have. Just a few examples that anything is insurable. I put this on here for Walter. This is Gene Simmons of the band Kiss. He famously insured his tongue. Satellites don't go into orbit without insurance. You can imagine that railroads insure their locomotives and cars, but they also insure the tracks that they ride on, which is a difficult risk to insure. And then David Beckham insured his legs, so his livelihood. You can imagine that planes don't fly, and we certainly don't operate without some sort of transfer of risk in place. So this is Lloyd's in its present state. Types of insurance, mainly you can break them down really into two main entities, life and property and casualty. Medical malpractice falls under the casualty part of property and casualty. Reinsurance is something that's more specific to insurers, and it's insurance companies buying insurance. Insurance markets, you have admitted or standard companies. These are admitted in the states where they are conducting business, and what that means is insurance is a service that's been largely left unregulated by the federal government somehow. And all 50 states are free to regulate it as they see fit. And every state has an insurance commissioner. And they ensure that states or insurance companies are abiding by the laws and regulations in their state. And one of their main duties is to make sure that the insurance companies stay solvent. And what that means is that they have enough capital on hand to meet their obligations, whatever they may be. And then you have non-admitted companies, and in the industry lingo, these would be excess and surplus lines companies, and then Lloyd's would fall into that category. And these are for very difficult to insure risks, and you don't get that same level of protection as you do with going with an admitted company. So you have, breaking it down further, you have direct writers, an example of which would be GEICO. You, the insured, goes directly to the company for your auto insurance, and then you have indirect writers. And you access these companies through an agent or broker. And you know, an agent, they're both terms that mean something. An agent is an agent of the company. That is where their fiduciary responsibility lies. A broker, their responsibility is to you. But don't confuse that these individuals don't get paid unless they sell you something, so their interests are really, you have to keep that in mind, that they're also trying to make money as well. Stock versus mutual companies. Stock companies are typically publicly traded. Because of that, management's, loyalty is to the shareholders. They're focused on a shareholder return. Advantages of going with a stock company or being a stock company is they have access to capital. If they fall on hard times, they need to raise more capital to pay claims. They simply issue more stock. And because of this, they're potentially more financially stable versus mutual companies where the owners are the policyholders. They're not focused on shareholder returns. They're focused on their members. Because of this, they're able to possibly offer you lower premiums. And if a company makes a profit, it can be returned to the policyholders or owners as a dividend. And this isn't taxable, so that's kind of a plus with those. All companies are rated. These are some of the major rating agencies. They mostly stick to an alphabetic rating system, with A being the strongest. AM Best is probably the best known. Their strongest rating would be A++, and it goes down from there. So why care about medical malpractice insurance? It's something that you'll all need for the rest of your career and even after. In the event of a claim, it'll protect your livelihood, assets, and reputation. And it might, settlement of a claim or losing a trial at court where you owe monetary damages can place your name in the national database for malpractice claims. And as physicians, we're all likely to be sued at least once during our careers. At least that's what the statistics say. And here's, for our specialty specifically, this is 2017 data, but we're at the top of the list for those most likely to be sued. Main reasons: failure to diagnose or a complication from treatment. It can eat up a large amount of your time. You might spend weeks away from work where you're not earning a salary or wages. And it can take a long time, which can cause a lot of anxiety, mental anguish, and once again, time away from work. So what is medical malpractice? Briefly, it's medical negligence. And it falls under some basic tenets of tort law in that there's a standard of care. The standard of care was violated. You have an injury, and it resulted in damages. For our profession, it is a standard of care from the rendering of professional services. And that standard of care is what would a reasonable physician do. Professional services, that would be medical treatment, making a diagnosis, or even rendering a medical opinion. Sometimes you can be drugged into a lawsuit by getting stopped in the hallway and having a brief 5-minute conversation about what you would do with a patient, so be careful. But bad outcomes do not equal medical malpractice, and it's something we deal with every day. We have bad outcomes, but that doesn't mean that we did anything wrong. Medical malpractice, it exists because bad things happen, and we get sued sometimes. It's an insurance that specifically addresses this liability from the professional services that we render. It's not offered by every insurance company, and there are brokers and agents that specialize in this market if you're uncomfortable accessing it, a direct writer on your own. So some basics about liability insurance. It's either going to come in one of two flavors, and the first would be an occurrence policy form, and this would be the most basic. This is what all your general liability coverage is going to be written on, and this is going to cover the person that's going to come into your office and slip and fall and then sue you because their leg hurts. It's simply triggered by having coverage at the date when the injury occurred. So if a person fell in my office on December of last year and filed a claim this year, the 2018 policy would cover that because that's when the injury occurred. All that needs to happen is that you have coverage in place at that time. In contrast to a claims-made policy, and this is pretty much the standard for how medical malpractice is written, and it's a little bit more nuanced, meaning that coverage is triggered differently, and it all happens around the dates. So when the policy is written, it's written with an effective date, like January 1st of 2019, and it's written with an expiration date. And then it has a retroactive date, and this date is typically the first date or the first effective date that the policy was issued by the insurer. And then you have an extended reporting period, and this is typically 60 days after the end of the policy. So to trigger a claim under this form, a claim has to be brought after the retroactive date, but before the extended reporting period expires. So I have some examples. This would just show you that if an incident occurs in 2016 and is reported in 2018, as long as the retroactive date was before 2016 and you still have coverage in force in 2018, the policy will cover it. Another example, the retroactive date was 1/1/2014. The incident was reported in 2017. The policy would cover it. In this example, the incident occurred prior to the retroactive date and was reported within a policy period where you were covered. Because it occurred prior to the retroactive date, it would not be covered by your insurer. So why is this important? it leads to potential gaps in coverage, and you'll need to figure out how you want to address those and your appetite for risk. So tail coverage, we mentioned the extended reporting period. This is an endorsement to an existing claims-made form that extends the reporting period, and it's expensive. Premiums typically are 200 to 350% of the annual premium. Fortunately, as I'll get into in a minute, it's been a very favorable medical malpractice market for insurers as of late. They've made a lot of money, and because of that, you see increasing competition and more companies willing to offer standalone tail coverage. It used to be that you had to purchase tail coverage from the insurer you were doing business with at the time. And this is how it would work. Let's say your last policy period was in 2018, and from whatever reason your business changed, and you bought tail coverage. Anything that occurred within 2016, 17, or 18 when you had coverage and was reported later outside of those coverage periods would be covered because you had that tail coverage. So more on medical malpractice underwriting. When you go and apply for coverage, they're going to take into account all of these things. Your education, where are you trained, how many years you've been practicing, stability of your practice, frequent moves. If you're moving around a lot, working, jumping around to different partnerships, different employers, or have gaps in practice, these can be telltale signs of a problem, and it might tune the insurance company in to dig a little deeper and look at that. Your practice setting, of course, your loss experience, any sanctions or reprimands you have, or board actions. So if you find yourself in the database that I mentioned earlier, the insurance company is certainly going to look at that and take that into account when they offer you a quote, or if they offer you a quote. And then when they put a price on what to charge you, they're going to take into account the procedures you're performing. Are they high risk, like cosmetics? The retroactive date, of course, how many years you've been practicing. The limits of liability you're requesting. Are you requesting more than the average or less? The state and how litigious it is. And then if you're working full or part-time. Some carriers, as you slow down in your career, are willing to offer or charge you for part-time coverage if you're only working that much. And limits, typically they start at $1 million per occurrence and $3 million aggregate. Well, what does that mean? That means that for a given policy period, which is typically a year, the policy will pay no more than $3 million in total, but no more than $1 million per claim. So you can have 3 claims totaling $1 million that the policy pays out brought against you before you exhaust your limits. Now you can purchase this up to $10 million per occurrence and a $12 million aggregate limit, but getting limits higher than this is difficult. You should decide what limit you're willing to choose based on how much you have at risk, your appetite for risk, and the local legal environment and how litigious it is. Why does this matter? You're either going to receive coverage through employment under the hospital's policy, or it can be purchased individually or through group policies if you're in a partnership. There are potential for coverage gaps when you change jobs. The extended, for example, if you're working here at Erlanger and your contract expires and you want to go to work at Memorial, you're probably going to have to get a new medical malpractice carrier. And you still, what you did here at Erlanger, you'll still be liable for under the statute of limitations, which I'll get to in a minute. So under your new policy at Memorial, you will not have any coverage for what you did here at Erlanger. So that's why tail coverage is important. Your policy can be canceled or non-renewed. If you move to a different state, it's almost like starting over with medical malpractice. You'll probably have to go through the motions, the underwriting exercise all over again, and you'll probably need tail coverage for what you did in the state from where you're moving. And if you retire, the things you did prior to retiring, you can still be liable for due to the statute of limitations. And finally, you'll likely be required to have it when you go through the credentialing process. I think any hospital or anybody worth their salt would probably want to make sure you have some type of coverage in place. So Tennessee Tort Reform of 2008, it did three things, main things. It established a statute of limitations, and that means that claims must be brought within 1 year of discovery, but the injury must have been deemed to have occurred within the past 3 years. It limited damages, specifically non-economic damages, to $750,000 except in extreme circumstances. What are non-economic damages? This would be pain and suffering. Economic damages remain unlimited, and that's a reason to consider higher limits. If a bad outcome were to befall a young person who was otherwise healthy and a high wage earner, that could be a very large amount in terms of the lost wages and the medical bills he would see through the course of his life that could add up to be a very significant sum. And then finally, one of the bigger things is the expert witness requirement of all plaintiffs now here in this state. Plaintiffs must submit an affidavit of merit within 90 days of filing a claim. And what does this mean? It means that they must seek out and find an expert witness that must be licensed in this state or surrounding state. Their specialty must be relevant to the case. They must have practiced in the specialty in the year, at least 1 year prior to when the injury occurred, and they have to be willing to say that the claim has merit before it can move forward. And if the plaintiff can't deliver this, then the case can be dismissed with prejudice. What has tort reform done for this locale? Well, it's ushered in a market or a period of market stability. Insurance companies have made an underwriting profit in over all of the years in the past decade. This has translated into lower premiums for physicians, and it's made it a more desirable place to work, attracting more physicians to the state. Will it last? Non-economic damage caps have not been tested in Tennessee. Of course, the trial lawyers hated this and hated to see it come about because it certainly impacted their income. And tort reform was actually a broad bill to address all casualty claims. It was not specifically designed to address medical malpractice only. And as a side note, the person I spoke with at the SVMIC told me there is a case that they're watching very closely that could test some of these things and possibly do away with them. For chiefs and those negotiating employment, now is the best time to negotiate your terms. You need to determine who is responsible for providing your coverage, what limits you want, and then for those who are seeking employment with the hospital system, this is something you should definitely try to negotiate into your contract. And that's a consent to settle clause. What does that mean? It means that if you agree to be insured under the hospital's policy, you might be, because you're an employee, you might be giving up this clause that is common in many insurance policies. What does that do for you? It means that the insurance company will not settle any claim on your behalf without your agreement. And that's important because when they do, your name goes in the practitioner database that we mentioned earlier. And that's not just for 5 years or 10 years. That's for life, and that'll follow you around anywhere you move and practice. So make sure that you try to negotiate that into your contract up front. And then have your contract reviewed prior to signing. There are people out there who are familiar with what's normal in the industry. I was told that the SBMIC has people that are familiar with this, and they'd be happy to look over anything. It's not legal advice, but they can tell you if something is not normal. So for the consent to settle clause, you can see that roughly 17%, the insurance company or their hospital decided they were going to settle the case, and that was whether or not you agreed with it, because they didn't have that clause in their policy. Encouraging to settle is a little bit different. Claims do have merit sometimes, and sometimes you should pay. So I think insurance companies tend to know when something has merit, and they're more apt to encourage you to settle. And a lot of times that's better for all parties when that happens in a timely manner. So claim trends. Trial lawyers know that the electronic medical record is upon us, and they have seminars that they are going to learn how to use it against you. So be careful when you're documenting, and don't just click buttons. Be careful with your dot phrases. If you say that you reviewed all the data, be sure that you reviewed all the data. For example, they have figured out how much screen time you spend on a specific page. So if the patient didn't get started on the right antibiotic and you were on the microbiology page for 0.2 seconds, they can see that. And if you attested that you reviewed all the data and didn't change the antibiotic after that, well, then you might be culpable in that instance. And then as far as documentation, less can be more. These electronic medical records are notorious for generating pages and pages of data that a lot of it's fluff. But a simple sentence just stating what's going on with the patient and that you're monitoring their hematocrit drop and you're going to check it in another 6 hours can save you a lot of headache potentially in the future. And then finally, be careful when you're examining members of the opposite sex and have a chaperone. And I guess in today's day and age, that goes for anybody that you're examining, because there's a rising trend in sexual misconduct claims with physicians, so I'm told. Insurance is more than just paying claims. It provides expertise, mainly legal expertise and defense. Going to an average attorney off the street for medical malpractice defense is probably not a good idea. Your insurance company knows who to call and knows they know who is good at these types of things. They also provide audits and risk management services that you should take advantage of. Some provide practice management services, and then contract review, as I mentioned. And these are things that I guess you're paying for with your premium, and they see, these insurance companies see what everybody is doing out in the market. So they have a good idea of what's going on, and they can offer you some tips to stay out of trouble and even run your practice a little bit better, potentially. So what ultimately happens with lawsuits? You can see that many don't make it to trial. Some get settled. Very few go to trial and get settled or get returned with a verdict in favor of the plaintiff. And then takeaways. Understand the medical malpractice marketplace. Your insurance carrier is your partner and does more than pay claims. Don't have a coverage gap if you have a change in your career. Negotiate terms of your employment up front. Know the jurisdiction in which you're going to practice, and more specifically, know the statute of limitations, if there is one. Tort reform has been a positive for our profession, and Don't let trial lawyers erode it, and to that extent, that means being politically aware and active and supporting organizations that advocate on your behalf. So on to probably the main takeaway from this is the cost of medicine. So when plaintiffs do win something or get a monetary award, how much is it? And you can see that very few go into the millions. Most are under $1 million, but it's still a significant sum. Here in Tennessee, the average cost of defense alone is over $100,000, which makes your policy or premium very worthwhile if you are to get sued. And that includes the cost of expert witnesses that they'll have to bring in on your behalf. The average settlement or verdict for our specialty is between $300,000 and $400,000 here in this state. And then for our chiefs, what you can expect to pay next year when you enter practice is $12,000, and that's before any discounts. Don't be surprised in the second year, third year, and fourth year when your premiums go up, because they will, and that's part of it. And that's because in your second and third year of practice, you'll have more exposure. You'll have more patients as your practice grows, and the insurance company is going to charge for that. It should finally level out once you hit your stride at around $29,000 or $30,000. How does our specialty compare to everyone else in this state? This is data from the SVMIC for last year, showing premiums for basic policy limits of $1 million per occurrence, $3 million aggregate for a variety of specialties. And you can see we're on the higher end. And then we can contrast this to premiums in New York, where they do not have any tort reform. And you can see that right here, the average filed rate is $120,000 a year. The insurance companies do have quite a bit of leeway to apply credits and make that premium lower, but that's kind of their starting place right there. So quite a difference. And these are my references, and once again, I'd like to thank Ms. Schroed, and I'd be happy to take any questions.
Questions, comments, Dr. Greer?
That's a great talk, Luke. We appreciate that. Just some points. I've been sued twice in my career. Both times I was dropped, but the first time was for $10 million on a trauma case. So that'll catch your attention when that happens. I was dropped from the suit. It was a drunk that ran off the road, hit a tree, had a neurological injury. Anyway, it was miserable, but I got off that. I've never been successfully sued, but I've been through it a couple of times. I think one of the things important, if a complication does occur, you need to tell the family and chart it that day or soon, so that statute of limitations starts running. I would also suggest that you get consultants if you have a problem. Sometimes you don't want a consultant because they may highlight your problem that you had, but they will help you. And then something else I've read recently is that if you are sued, do not go and look at that chart on the computer. Apparently that is a negative thing. If you've gone back and you've looked at it after you've been sued, I don't know if you've read about that. This is more into the actual process, not the coverage that you're speaking about. But I had read that, and I don't know if you saw that. Again, not part of your talk really, but
I don't know about that, but amending the medical record after the fact is a no-no.
You've cooked your goose if you do that. Do not change anything.
Yeah, you're on the hook if you do that.
The tort reform has made a huge difference for us, because I mean, before tort reform, malpractice was very common. We fought this all the time. I mean, it's made such an incredible impact. And the people who practiced after 2008 don't realize how risky things were back then. So it's made a huge difference to me. It's been life-changing so far as our practice. So it's been a great thing. And SVMIC has been a great company. Anytime you have a question or a patient says, I'm going to sue you, or whatever, you just call them and let them start helping you with that case. Because you will have people who tell you things that you find very threatening. They may tell you, so call them up and get them on the phone. They can help kind of get you through the process and tell you what to do and then what not to do. So I think it's been a great company.
I think that's one of the biggest takeaways is even if you have a suspicion that there's a possibility you might be sued. This isn't a plug for the SVMIC, but I was very impressed with them. You call them up, they don't have claims people that answer the phone. They have a claims attorney that can give you a claims attorney answering the phone. And he will give you, or he or she will give you legal advice, what to do right then and there and how to proceed. And I think that's very valuable.
The hospital requires you to have 1 in 3 million coverage. Most of us have more than that. In vascular surgery, I think I have 4 in 6 or 2 in 4. So it doesn't cost that much more, I don't think, to bump it up. I can't remember the difference between 1 in 3 and 2 in 4 and all that business. But you're required to have 1 in 3, which today I don't know if it's enough or not. But that's something you can think about when you sign the contracts.
That I would, just knowing from what I know, I would think 1 in 3 would be on the lower end of what you'd want to carry. And it's not that hard to ask your underwriter to quote you some higher limits, and you'd be surprised to see that they don't cost that much more.
They don't. That's true. They don't. Because for our practice, we have moved it up for almost all of our faculty here. Other comments before I start? Okay, back to Dr. Greer's point. I've done a lot of testifying on behalf of physicians and over the years, so unfortunately, almost all of this, I know this was a very, very good talk. So let me just review a few things. The chart review that Dr. Greer pointed out, I'm aware of a case that had to be settled for a lot of money because it was proven that the doctor went back and changed the chart after the fact, and it occurred within a 40-mile radius of us here in Chattanooga. Because I got involved in that one, and it was indefensible. You can't defend something if you prove that the doctor changed the record. So as tempting as it may be to do that, just know that you're not going to get away with it, or you're not likely to. If the case has already been filed, they've already figured out what's in that. They've seen that chart, and so they can document any change that has occurred. Because that one was very defensible, except for that was indefensible. And so the case ended up costing quite a lot, because this is prior to malpractice reform. This case occurred in the 80s, when malpractice problems were much greater. A little bit about the history of SVMIC and why it's so good. You mentioned a lot of things that are good about it, and it is really, frankly, a standard in the industry nationwide, as you probably found out. The services that they offer are really great, and the reason is because we, the policyholders, actually own the company, right?
Yes, sir. That is correct.
A volunteer mutual company. And so as a result of that, you have physicians there that are looking out for your behalf, but still have to be realistic from a business standpoint. When I started on the faculty in 1974 in Memphis was when the huge crisis hit. We had a period of time, actually, for about 9 months where a physician who had been already practicing in Tennessee could not buy any form of malpractice insurance. And I ended up, because I just started the faculty, started out cheap, like you pointed out. I was the only insured faculty member in the University of Tennessee in Memphis for certain things. And so certain cases, I had to do them all or be the faculty support for all, because I was covered and my mentors, who were nationally recognized surgeons, weren't. So it can be a huge crisis. From that, State Volunteer Mutual was created by physicians, mostly surgeons, quite honestly, to take care of that. We then had, and so then you could buy insurance through it. And it was still very expensive, as Dr. Greer pointed out. We then had the next crisis is that, but who's going to defend us for what you do, residents, medical students? So that was a crisis, because you had faculty members running and abandoning an education completely. And so SVMIC offered a premium discount if you would be a full-time faculty member of the University of Tennessee. And that has persisted, frankly, for us here in Chattanooga to this date. Now, they've denied it in Memphis in certain specialties there because they're, again, back to the business side, their experience has not been as good as ours has been in terms of being able to successfully defend cases or not have them filed. And so, for example, our faculty here still gets that discount because we're full-time faculty of the UT, but also because our experience in malpractice is as good as it is. So that's some of the history involved. Talking about hospitals having to have it, those of you that are chief residents, why would you have to have it? Well, you say, wait a minute, I'm American, I don't have to do this. Well, the reason is if somebody filed a malpractice suit against you and it occurred in the hospital, if you're not covered, then if they can successfully sue you, then in Tennessee at least, the judge or the jury can apportion how much of that settlement is designed to you, is assigned to you or the hospital. So the trial lawyers always go for the deep pockets. So in that case, the deep pockets would be the hospital. So the hospital, you have no insurance, so they say, well, what are we going to do? Get his house? You're just starting out. Maybe you got an expensive house, $200,000-$300,000. But I mean, that's nothing to a trial lawyer. So I mean, and time that you get it back, and everything, it ain't going to make them any money. So they go to the hospital for the money because they got the deep pockets. So that's the reason that most hospitals are going to require you to at least have a baseline coverage there, so that you would share that responsibility. The consent to settle. Let me see just a minute. Okay. Pediatric surgery, for example, when you go through, is very interesting about your limits of coverage and the time involved. If you look at that, and Dr. Kelly may want to comment on this, it's about how long are you exposed to risk, because it depends a lot on the patient you're treating and the involvement. Pete, you want to talk about that just a minute?
I think unless things have changed,
use the mic, will you?
Unless things have changed, the statute of limitations used to be up to patient age of 18. So, you operate on a baby and you're liable for 18 years rather than the typical statute of limitations. And I don't think that's changed.
Yeah, I think that's true. So, their liability was extended considerably compared to what ours is. Now, again, remember, Luke pointed it out and made the emphasis, but I want to reemphasize. You noticed when something happened, which is the 3 years, but when did you find out about it? So Dr. Greer's point, if there is something there that you have a concern about a potential liability for, then you want to be sure that you have documented that the patient or the family or someone that's a responsible individual knows. And that would, I guess, pertain to pediatric surgery particularly.
Yeah, and I think for pediatric surgeons, especially when you're looking at tail coverage, and if you're liable for people for 18 years after you retire, then you're going to have a lot more tail coverage. But I haven't really looked into the details of that, but I'm sure it applies. There was one other thing I wanted to mention.
Sure, please.
The EMR really worries me about all this, because I think that's going to really open up some areas for the lawyers to exploit. And one of the things they mentioned about never going back and changing the record once you've been sued, that probably applies. I mean, even when you haven't been sued, you can go back and edit the EMR, and I think most people are savvy enough to know that the EMR keeps an audit trail. If you go back and edit one of your progress notes, you'll look at it and you don't see the changes. It looks like the edit, but if you go back and look at the history, it shows all of the stuff that you struck out and stuff you put in, all the changes you made, the exact dates and times. So say you've seen some patient and you didn't you weren't really on track, and then something bad happened, and you come back after the surgery, maybe I ought to tweak that consult note a little bit. You know, you haven't been sued, but if you wind up getting sued, I mean, that change will be seen. It's easy to discover, so you really have to be careful about even just going back and, you know, fluffing up or editing a note or something, because if it does wind up in a suit down the road, they're going to see that. And then I really hate the gobbledygook that you see in there. I mean, even from us, even from myself, I see the kind of trash that goes in there, and we're, you know, that's going to be a problem. I think the lawyers are going to take advantage of all that.
Yeah, I agree with you. I've had that concern ever since we started talking about this being something that was going to be the standard of care for America. And talking about progress notes, it is so tempting to point out what someone else did wrong and just know that that comes back to bite you. I'm aware of a case in this hospital where two surgeons who don't like each other have documented things like that in the progress notes, and all it's going to take is for a lawyer to get a hold of that, because you see the standard of care that Luke gets to. That's one of their favorite things. For those of us like Dr. Rowe and Dr. Greer who have helped people defend lawsuits, maybe many of the rest of you, the standard of care is what goes on in your community. And if you have said this patient suffered as a result of what Dr. X did, then they've got their standard of care. At least they can make that claim. Now, you can try to defend that, but it's a real problem. And so just be aware that anything you write in there, would you want a lawyer to review it? Now, on the other hand, we got to take care of the patient first. So do what you have to do. But remember that there are things like that, like what another doctor did, or words that many of you have heard me say before. You should strike from your vocabulary as a doctor. Every one of you look at me right now. You should strike the word inadvertent. Nothing happens in medicine that's inadvertent. It either happened or it didn't. And all you describe is what happened, not that it was inadvertent. Because again, would that be a standard of care that you commonly have inadvertent things occur? No. So you never say that word anymore except as it relates to shooting pool or whatever it is, casting, fishing or whatever. Dr. Greer, you got something else?
Yeah, I was just going to say, sometimes patients will use you to ask you questions that maybe try to implicate the staff that something wrong happened and why it happened. As a student or a resident, you only state the facts. Yeah, your fever, you got a temperature of 100 and you've got white count of 10,000. Why did this happen? That's not for your discussion. So be very careful with patients who try to get you to say things that are negative toward the faculty, because they will use you against them.
Well, or other doctors. I had a case last week. I had a new breast cancer case, just did last week. Her husband is intent that the radiologist missed her problem on her mammogram a year ago. And it would be real easy to say that happened, because looking back at the mammogram, you could maybe suggest that there was something there a year ago, but not really. So it'd be real easy to do that. And that's a case that I face quite a bit. Go back to one of your early slides there about why cases are scheduled or real early. Yeah, go on back.
Yeah, I think breast used to be the most common malpractice
That's what I was
claim.
going to make that point to everybody. Keep going. Okay, right there. Okay. Now, I haven't checked this in about 8 or 10 years, so I may be telling you something that's not exactly accurate now, but the number one reason, I know 10 years ago in defending a case, that the number one reason for malpractice suits being filed in oncology, in any kind of cancer, was breast. And that's why in this community, by the way, I mean, Ryan was with me yesterday, and I had to explain that we do a lot of follow-up of breast cancer patients because the primary care doctors don't want to they don't want to take that responsibility. Because there were several cases filed here in Chattanooga against primary care doctors about number one there, failure to diagnose. And you could have a breast cancer in this part of the breast and them have been having a problem over here, but that doesn't stop them from suing you. Now, they didn't necessarily win those cases, but they filed them. So that 10 years ago, which doctor was most commonly sued for breast cancer? Primary care. Primary care, general practitioner. What was number 2? OB. They saw the patient, decided you don't have a problem. Number 3, surgeon? No. Radiologist. Missed it last year. And way down the list at number 4 was surgeon. And almost none of the surgeons were successfully sued. Most of them were never successfully sued, but nonetheless you had to do the suit, which cost $100,000, as you pointed out. So it's still quite expensive. So failure to diagnose is really important. And as my old chairman in Memphis used to say, let's get some other doctors in here to share the responsibility. So you give people in that. Dr. Arnold heard that before. You share the responsibility for that. As far as tail coverage goes, Dr. Kelly is correct. It used to be really expensive because, especially in pediatric surgery, I think it's cheapened quite a bit lately, but because of the tort reform that we did get in Tennessee. It made a huge difference in Tennessee, and I'm glad you pointed out the difference between us and New York, because there are a lot of other states like New York right now. Florida, for example, Mississippi. Texas, on the other hand, is 10 times better than us. Yep. I mean, in Texas, it's almost impossible to sue a doctor now successfully, because they got tired of, because there were a lot of doctors leaving Texas at that time was the reason for that. I'll tell you a story about consent to settle, too, and the cost. We had a case here. I had a case that we went on for a long time. A couple of us were involved in it. It finally got around to getting filed, refiled, thrown out, whatever. But a very prominent malpractice plaintiff's attorney from Knoxville had the case. So they finally came around with me as the only defendant, and they came and offered to settle for some piddling amount of money. I mean, it was, I don't know, $40,000, something like that. So they said, well, you know, would you be willing to do this? And I said, well, you know, I don't really care. I'm older. Wouldn't matter, I guess, if I'm listed in that data bank, so go ahead and settle if you want to then. So that was our local attorney. So they took it to SVMIC. And SVMIC has a committee of doctors that look at cases and say, yes, settle it or don't. They sent back, we ain't settling this. The doctor didn't do anything wrong. Now, that caused me one hell of a lot of misery because I had to go through a week of testimony. I would think that SVMIC probably spent at least $200,000, if not $300,000 or $400,000, because of the expert witnesses they brought in. But that guy in Knoxville probably had to mortgage his house to be able to pay what he did. And he lost, and we won. The jury was out 45 minutes or something like that in that case. So the point is that committee at SVMIC said, we're not going to let this guy think that he can just file things without spending a lot of money and get anything back. And so you have to respect the fact that your company is run that way. So that was good. So they didn't let me settle. Said, no, we own this file. You bought from us, but we're not going to settle that because we're the ones that have to pay it, so we can't do that. On the other hand, as you saw from your data, an awful lot of times hospitals and others will do that, and then it does become your responsibility. So that consent to settle, for those of you that are chief residents, is something to really look at in your contracts, although I don't see many of them here, so I guess they're not hearing this. The last thing I would mention, and this thing about sexual misconduct, that really must have become a big deal because SVMIC now is really making a point to be sure that we are educated and that we, in our practice at least, do actually have chaperones and things like that all the time. So I guess it's become a pretty big issue. Any other comments any of you want to make? This was a superb talk, really. Yeah, Dr. Fisher.
One of the things that that I want to make sure you understood is that there's some big organizations such as Vanderbilt or the University of Tennessee in Memphis or maybe even Erlanger Hospital that they're big enough that they self-insure themselves. So they take a little bit out of every paycheck and put it in a big pot of gold in case you as a faculty member at Vanderbilt get sued, then they defend you out of that pool. So if you were to choose to go take a job at Vanderbilt, you're not going to have a choice of having your malpractice insurance through SVMIC. All the members of USA, I'm sure this is right, Mike, and both Mikes, but Philip, but all the members of USA, all 35 of us, have our malpractice insurance through SVMIC. So we have an individual policy with that organization. But for instance, if Chief Resident finished in general surgery and became a hospital-employed doctor, let's say in Johnson City, then that Johnson City hospital, you may not get your malpractice insurance through SVMIC. So if you work for that hospital for 2 years and then decided that you want to move to Memphis and take a job working for the Methodist Hospital in Memphis, then the malpractice company that was insuring you in Johnson City would probably not be the malpractice company that would insure you in Memphis. So when you left the job in Johnson City, you would need tails coverage, even though you're a young surgeon. You would need tails coverage to cover you for the statute of limitations in Tennessee, which is 1 year. By the way, it's 2 years in Georgia. It's up to the individual states. So if you're going to take a job in Johnson City and be hospital employed, part of that contract that you need to understand is who is going to provide your malpractice coverage, because if you ever leave that organization and move to another one, then you're going to have tail coverage, and that organization, Johnson City, is almost for sure not going to pay your tail coverage for the year after you leave Johnson City and go to Memphis. I hope I've made that clear. Have I made that clear enough?
That's true. Yeah, and I think Luke made that point too. I mean, that's one of the things to take into consideration when you're moving from one place to another.
That's exactly.
And the idea that your generation is going to, you're going to have multiple different jobs and work multiple different places compared to people like me and Dr. Arnold and Dr. Greer and Dr. Barker, who have spent their whole careers here. It's very different. Dr. Barker?
Yeah, just a quick.
It's not on.
It's on now. Quick question, does SVMIC insure in other states other than Tennessee?
Yes. The SVMIC does, I think, in all surrounding states now. I know it does in Georgia, Alabama, Arkansas, not Mississippi. Not. Mississippi is a hotbed right now of any kind of liability coverage. Some of those huge tobacco settlements, things like that, occurred in Mississippi. So I think they do Kentucky. I'm not sure about Kentucky. Kentucky has done some tort reform too, so they're better off. And I'm not sure about the Carolinas. I know Georgia for sure, and I'm pretty sure about Alabama. Does anybody else know? But it does, yeah.
I'm actually on the underwriting committee.
Oh.
On? Yeah. So I'm actually on the underwriting committee, and they do in Kentucky, they do in Mississippi, but not in the Carolinas.
Okay. What about Arkansas? I think Arkansas.
They do in Arkansas,
yeah. Okay. I'm surprised they would do Mississippi. Mississippi must have gotten some tort reform then that I don't know about. One other point, just to end with what, and you ended with this very appropriately. If you look at the difference in what doctors do in terms of supporting their PACs, political action committees, or whatever you want to call it, in either TMA, American College, or the AMA, it's minimal in comparison to what the trial lawyers do. The trial lawyers are unusually well-funded, and therefore they have well-funded lobbyists, and we don't have as good in that regard. So you really should have an organization that you hook yourself to, regardless of which one it is, that on your behalf can effectively represent you. And I say that because there's been a schism between the College of Surgeons and the AMA, for example, about who that really represent the best. Both, I think, try to do a good job. The college certainly does a really good job for us, the American College of Surgeons. So, but got to start thinking now about that being something that you do. Very good job, Luke. Very well done. Thanks a bunch.